Hi everyone. I hope everyone is doing fine and really hope that I would be able to share some useful information on the applied pelvic anatomy for urogynecology within the time allocated for me today. Anatomy can be very boring at times, but as a surgeon, including a urogynecology surgeon, we should master our anatomy, as this is crucial to allow us not only to understand the disease better, but to ensure we can perform the surgery safely and efficiently. Here is the outline of my lecture today. The main bulk will be on pelvic floor anatomy, followed by pelvic floor support, bladder and urethra, anatomy related to retropubic and transobturator procedure, and finally avascular spaces in the pelvis. Let's begin with the first one, pelvic floor anatomy. We all know that the bony pelvis is formed by three bones, which are ilium, ischium, and pubis. Some bony landmarks are crucial for all of us to be able to identify. For example, anterior superior iliac spine. We always use this for locating our secondary ports when performing laparoscopic surgery. Ischial spine. Not only we use it on daily basis for those who are still practicing obstetrics, but for urogyne, identification of ischial spine will be the guide for us to perform certain procedure. For example, sacrospinous fixation. Next is pelvic side wall. Pelvic side wall are made up of two muscles, the piriformis muscle and obturator internus. Here is the piriformis, which extends from the anterior lateral portion of the sacrum, then pass through the greater sciatic foramen and then attach onto the greater trochanter. This is the lateral view, so we can see the piriformis coming out and attach onto the greater trochanter here. Second one is the obturator internus, which originates from the inferior margin of the superior pubic ramus and passes through the lesser sciatic foramen to insert onto the greater trochanter of the femur as well. Next is pelvic diaphragm. Pelvic diaphragm is a term commonly used by urogynecologists to explain why pelvic organ prolapse occurs or why certain type of surgical procedure is performed. The pelvic diaphragm consists of the levator-ani and coccygeus muscle. This is the levator-ani. And posteriorly, here is the coccygeus. This is an atlas to view the pelvic diaphragm from superior, and I purposely make it upside down so it tallies with our earlier diagram. Here is the pelvic side wall, obturator internus anteriorly, and piriformis posteriorly. And here is the pelvic diaphragm, coccygeus muscle posteriorly, and levator-ani, the main bulk, anteriorly. Another structure that I would like to highlight is the arcus tendinous fascia pelvis, or ATFP. It's a thickened linear band of obturator fascia, and this thickened band forms an identifiable line from the ischial spine to the posterior surface of symphysis pubis. There are a few reasons why we should know ATFP, and we will know in a bit. The pelvic diaphragm has always been described as a hammock-like structure. As we all can see here, that these muscles of pelvic diaphragm create a continuous structure between the pubic bone from the front, the coccyx, from the back and the arcus tendineus fascia pelvis laterally. However, this view doesn't allow us to appreciate the concept of hammock-like structure. But this view can. From frontal view, we can appreciate the funnel-like levator ani that creates the hammock-looking structure. As much as the importance of the hammock to be strong enough to provide support to things or people on it, it is very crucial that the attachment of the hammock is well preserved as well to allow it functioning well. Same goes to our pelvic diaphragm muscles. It must be strong enough to support the pelvic organs above it, and the attachment of these muscles must remain intact. Otherwise, it will result in pelvic organ prolapse. Now we go through the components of levator ani, and this is superior view again. Levator ani consists of three distinct muscles. First is pubococcygeus, which originate from the posterior inferior pubic rami, insert at the midline on the anococcygeal raphe and the coccyx. Second one is puborectalis, which has same origin, forming a sling around the rectum and the vagina. And finally, the ileococcygeus, which originates from the ATFP and insert on the anococcygeal raphe and coccyx. This is the inferior view where we can appreciate the puborectalis better. We can see from here that puborectalis forms part of the perineal body. From a functional standpoint, the levator ani muscle, which are skeletal muscle, exhibit constant baseline tone and can also be voluntarily contracted. The muscle contains both type 1 slow twitch fibers to maintain constant tone and type 2 fast twitch fibers to provide reflex and voluntary contraction. It is important to appreciate that the constant tone of the pelvic floor provides a constant support for the pelvic viscera. Hence, the importance of pelvic floor exercise should not be underestimated, as this can improve both muscle tone and strength of contraction. And this must be emphasized as both preventive and therapeutic measures. Now the coccygeus muscle. Coccygeus makes up the posterior part of the pelvic floor, the pelvic diaphragm. It originates from the ischial spine, overlies the sacrospinous ligament, and inserts on the lateral lower sacrum and coccyx. As one ages, the coccygeus becomes thinner and more fibrous, often blending with the sacrospinous ligament. At times, distinguishing the two is difficult because of the fact that they have the same origin and the same insertion. Therefore, often this structure is identified as coccygeus sacrospinous ligament complex, or CSSL complex. It is an important anchoring point for vaginal prolapse surgery. This is an important structure. We shall discuss more a bit on it. It is extremely crucial for us, the surgeon, to appreciate the close proximity of the many vascular structures and nerve to the CSSL complex. This is a sagittal section of the pelvis. Imagine the patient is lying down with symphysis pubis up here, coccyx down here, and vagina is here. When we perform this section during the sacrospinous fixation procedure, let's say, we identify our ischial spine first. Then we expose the CSSL complex posteromedially. During the dissection, we must always remember a few things. First, the pudendal nerves and vessels lie directly posterior to the ischial spine. Second, the sciatic nerve is superior and lateral to the ischial spine. And the third one, there's an abundance of vascular supply, which includes the inferior gluteal plexus and hypogastric venous plexus. They lie superior to the ischial spine, so this area must be avoided. With regards to the anchoring point, due to these structures, we should apply the anchoring suture 2 cm medial from the ischial spine on the CSSL complex and careful not to go superior than the ischial spine and the CSSL complex. This is crucial to avoid significant bleeding and nerve damage. Next, let's revise on perineum. Preferably, we view it from inferior. The perineum is divided into superficial and deep component. These two components are separated by a fibrous connective tissue layer called the perineal membrane. It is a triangular sheet of dense fibromuscular tissue and sometimes also referred to as the urogenital diaphragm or urogenital triangle. I hope you can appreciate this rather translucent structure in this diagram. The perineal membrane also provides support to the distal vagina and urethra as they pass through it. If we turn the diagram more horizontally, I hope you can appreciate that the perineal membrane divides, this is the perineal membrane, it divides the structure deeper to it into deep perineal pouch and structure superficial to it into superficial perineal pouch. Okay. We go to the deep perineal pouch first. This is coccyx. This is the anterior part, the pubis. So if we remove the perineal membrane just now, these are the structures within the deep perineal pouch. We have deep transverse perineal muscle, also attached at the perineal body here. We have compressor urethrae, uretrovaginalis, in which both of these structures are part of the external urethral sphincter. And now, if we add back the perineal membrane, here are the erectile tissues, which are the component of the superficial perineal pouch. Medially, we have bulb of vestibule, and laterally, we have crura of clitoris. And please note that they are connected anteriorly at the clitoris. Next, we add other structures in the superficial perineal pouch. They are superficial transverse perineal muscle, and you can see two other muscles are located superficial to the erectile tissues. We have ischiocavernosus superficial to the crura and bulbospongiosus superficial to the bulb. The primary role of these two muscles is to maintain erection by pushing blood to the clitoris, and they do not have much role on support. Now we have completed the urogenital triangle. Let's talk a bit on the anal triangle posteriorly. This is predominantly fat-filled space that contains nerve, vessel that are passing to urogenital triangle anteriorly. In the midline, we can see an anal opening and external anal sphincter. The fat in the anal triangle extends anteriorly into the deep perineal pouch, but not superficial perineal pouch. This knowledge allows us to understand that infection in this area can spread quite easily, making more extensive infection in the pelvis. Last but not least, another important structure which I believe you all know is the perineal body. By now, we should be able to appreciate that there are many muscles attached to it. For example, levator-ani muscles, deep and superficial transverse perineal muscle, bulbospongiosus, puborectalis. Hence, the integrity is crucial as it provides major support to the pelvic floor muscle. Any defect on the perineal body will lead to significant weakness of the pelvic floor, which can lead to conditions such as pelvic organ prolapse and stress urinary incontinence. So just to recap, we have completed the pelvic floor anatomy section and now we shall discuss the rest of it. Next, let's talk about pelvic floor support. A normal pelvic floor support is provided by an interaction between the pelvic floor muscles and the connective tissue attachment. Of course, the primary support of the pelvic floor comes from the pelvic floor muscle. It provides a firm yet elastic base on which the pelvic organ rests. However, the connective tissue that we name it as endopelvic fascia also helps in stabilizing the pelvic organ in an appropriate position. For example, during micturition or defecation, the pelvic floor muscle will relax, while the connective tissue attachments or the endopelvic fascia will temporarily stabilize the pelvic organs. So, the endopelvic fascia is a network of loose connective tissue. It loosely connects the pelvic organ to the supportive musculature and bones. It provides stabilization and some support. At the same time, it allows mobility, expansion, and contraction of organs. Because structures, for example bladder, will need to be filled up by urine and it needs to expand, and endopelvic fascia allow this to occur. Histologically, the endopelvic fascia made up of collagen, elastin, adipose tissue, nerve, vessel, lymph channels, and smooth muscle. For the pelvic floor support, we currently rely on the Delancey 3 level of support, which describes the level of support of the pelvic floor divided into 3 levels. Level 1 for the upper part of the vagina and cervix. Level 2, the support is the middle part of the vagina. And level 3 describes the support to the distal third of the vagina. Okay. For level 1, it is provided by the uterosacral cardinal ligament complex posterolaterally. This maintains the vaginal length and keeps the vaginal axis nearly horizontal so that it rests on the rectum. This position allows the cervix to stay superior to the level of the ischial spine. For level 2, the support is provided by the endopelvic fascia, the paravaginal attachments, along the middle length of the vagina to the white line laterally, to the ATFP laterally. And for level 3, the support is provided by the perineal body and perineal membrane. These structures support and maintain the normal position of the distal 1/3 of the vagina and introitus. It is important to remember that all three levels of supports are interconnected through the continuation of endopelvic fascia. Maybe for analogy to help us remember better is that the muscles behaving as the main actor or the main actress for this pelvic floor support movie, and the endopelvic fascia as the supporting actress. Even though they're just supporting, but without them, we can't produce the movie. Next one is bladder and urethra. The bladder is a hollow muscular organ that is the reservoir for the urinary system. The anterior bladder is extraperitoneally adjacent to a retropubic space or radius space. The bladder rests inferiorly on the anterior vagina and the lower part of the uterus, separated by endopelvic fascia. The female urethra is approximately 4 cm long and averages 6 mm in diameter. Its lumen is slightly curved and as it passes from the retropubic space, perforates the perineal membrane and ends with its external orifice in the vestibule directly above the vaginal opening. Throughout its length, the urethra is embedded in the adventitia of the anterior vaginal wall. Further info on bladder. The bladder wall musculature is often described as having 3 layers: the inner longitudinal, middle circular, and outer longitudinal layer. However, this layering occurs mainly at the bladder neck. The remainder of the bladder musculature is made up of fibers that run in many directions, both within and among the layer. The next important structure in the bladder is the trigone. It is a triangular area in the bladder base and has a flattened appearance with a smooth epithelial covering. The corners of the trigone are formed by 3 orifices: the paired urethral orifices and the internal urethral orifice. The superior boundary of the trigone is slightly raised area between the 2 urethral orifices, and we call this as interurethric ridge. The 2 urethral orifices or opening are slit-like. In an undistended bladder, it lies approximately 3 cm apart. This is another representation of the bladder, so we can appreciate its relationship with surrounding organ. And maybe we can appreciate how the ureter courses medially below the uterine artery over the lateral vaginal fornix and travels through the wall of the bladder until it reaches the trigone. This distal part of the ureter is the most common site of injury during any gynecology and reconstructive procedure. Hence, we need to be very aware about this. Next one, we shall discuss a bit on anatomy related to retropubic and transobturator procedures. First, let's see the pathway of retropubic tension-free vaginal tip procedure anatomically. First, we shall make a 1 cm abdominal skin incision on each side of the midline. Usually, the landmark would be 2 cm from the midline and 1 cm above the pubic bone. Okay, that is for the abdominal incision. Then we shall go vaginally. So this is the overall sagittal section, but as we enlarged the diagram, we can see here, this is the urethra, this is the bladder, and this is the vagina. Okay, in this diagram, this is a vaginal cuff, there is no uterus. So we'll go to the vagina and we'll see the urethral opening. Okay, this is the urethral opening and this is the vagina. We need to make a 1 centimeter vertical incision. Some people will do 1 to 2 centimeter vertical incision, about 0.5 centimeter below the urethral opening. In some situations, there are surgeons who shall measure the length of the urethra using ultrasound and will estimate where is the middle portion and will perform the vertical incision as appropriate. Once we've made that incision, we shall perform a lateral dissection from the incision. So we shall tunnel about 0.5 to 1 centimeter long using sharp dissection to each side of the urethra. So we shall do right side of the urethra and also left side of the urethra. So this area is called periurethral space. So we shall perform the dissection in this periurethral space directed towards the ischiopubic rami. So we can use the urethral guide wire to direct the urethra away when we perform the dissection if we want. Once we completed that, we inserted the TVT needle into the developed periurethral tunnel aimed toward the ipsilateral shoulder. Once the needle passed through the urogenital diaphragm, the needle must be angled to ascend vertically through the retropubic space, making sure to maintain contact with the back of the pubic symphysis and bring it to the previously made abdominal incision. So the pathway of the tape will be from here, go to the periurethral tunnel, pass through the urogenital diaphragm, and once we've passed through, we must make sure it ascends vertically at the back of symphysis pubis and bring it to our abdominal incision. So this is another view from inside. So if we perform the procedure as described, we may see the TVT needle will pass through the Ratzier space, a very safe space because there is no vessels in the Ratzier space. In one of the published literature, they measure the distance between the TVT needle inserted and the major vessels, and they found that the major vessels, once we perform this retropubic TVT procedure, lies 0.9 to 6.7 centimeter lateral to the TVT needle. Therefore, if the tension-free vaginal tape needle is laterally aimed or rotated, we still can have a major vascular injury. But if we keep it as per described, keep it medially and exactly behind the symphysis pubis, we can avoid this injury. This is a diagram showing how a completed TVT looks like. So it should lies below the middle portion of the urethra. Okay, go through the side of the urethra, going up behind the symphysis pubis in the radius space and come out here at the abdomen in incision. Next is the transobturator procedure. So we need to understand certain level of anatomy to allow us to perform the transobturator procedure safely. So of course we need to know about the obturator foramen. So the obturator foramen is formed by the rami of the ischium and the pubis. Ischium and the pubis. So obturator membrane covers this foramen and it is continuous with the periosteum of the enclosing bone. So obturator canal from inside the pelvis that carries obturator neurovascular bundle will pass through the foramen and exit from the pelvis. And this obturator canal containing the obturator vessels and nerve is very lateral and superior to the ischiopubic ramus. It's about 3 to 4 centimeter from the ischiopubic ramus. So from another perspective, I just tilt it a bit so it's easier to imagine. So this is the obturator canal. So we aim somewhere here at the ischiopubic rami. At the same time, be careful because inferiorly there will be pudendal canal as well, which carries the pudendal vessels and pudendal nerve. Hence, we must aim for the safe entry zone for our TVTO needle insertion, which is around here at the ischiopubic rami. Okay, we shouldn't go too lateral and superior, we shouldn't go too inferior, and even in the center here because there is nerve passing through. Okay, now let me go through with you the procedure of performing TVTO anatomically. Okay, so we may start with the vaginal incision. So we need to identify the urethra opening. So we need to make a 1 to 2 centimeter vaginal incision at the mid-urethra area. Usually it's around 0.5 to 1.5 centimeter below the urethral opening. We dissect the vaginal epithelium away from the endopelvic fascia, so creating like a tunnel, directed to the ischiopubic rami. So we make an incision, we dissect the epithelium away, we create like a tunnel or a flap, directing towards the ischiopubic rami. Okay, we should be able to put our index finger in the tunnel to reach the ischiopubic rami because this will be a guide for us to locate the incision that we want to make at the groin. Okay, once we have identified the lateral margin of the ischiopubic rami, please make sure that it is located below the insertion of adductor longus. Okay, this is the adductor longus. So it should be somewhere here, and it is often at the level of clitoris. Once we have identified the site at the groin, we make about 1 centimeter incision. Okay, then we can take the TVTO needle. We should hold the needle using the same hand as the side that we are working on. Let's say we are working on the left side, we should hold the needle using our left hand. Okay, the other hand should remain in the tunnel that we have created towards the ischiopubic ramus. Then we shall hold the needle vertically with the handle downwards. Apply slight pressure because we need to pass through gracilis first, subsequently adductor brevis, which is located below gracilis, and then obturator externus, which cover our obturator foramen from outside, and then we shall perforate the obturator membrane. Once we reach there, the needle will curve around the ischiopubic rami, further perforate the obturator internus, and will direct it using our finger to perforate the periurethral endopelvic fascia that we have created a tunnel. So it should curve nicely around the ischiopubic ramus, making sure the needle always remain in close contact with the ischiopubic ramus. It's like curve around the structure and comes out at the periurethral endopelvic fascia that we have created the tunnel in. So by doing so, this is how the TVTO tape should appear like at the end of the procedure. It should come out at the groin, lateral to the inferior pubic rami, away from the superior and lateral part of the obturator foramen, because we know there is obturator canal there, and also the lower part, because we know there is a pudendal canal as well, and structures of the obturator nerve that pass through the foramen. So we should keep really at a safe zone at the lateral side of the ischiopubic rami. Okay, this is to distinguish how the retropubic tape appears like at the end, and this is the transobturator tape. So if we can understand the structures, the relationship between the pathway of the tape that we're going to put in with the structures around it, I believe we should be able to perform the procedure safely. And for the final bit of the lecture, I would like to just touch a bit on the avascular spaces in the pelvis. This diagram shows the avascular spaces available at the pelvis. It is important for us to know these spaces when we perform any reconstructive pelvic surgery. These spaces lack blood vessels and nerves. They are just mainly filled up with loose areolar tissue. Hence, it allows us to perform some level of blunt dissection rather safely. For example, during vaginal hysterectomy, during the anterior dissection to enter the vesicouterine spaces, we have a vesicovaginal space where we can go in and get the planes quite easily to enter the vesicouterine space, and posteriorly to enter the pouch of Douglas, we should be aware there is a rectovaginal space with no vessels, so it's a place where we can dissect and enter either sharp or blunt dissection, but this is an easier plane to go through to enter the pouch of Douglas. Okay, as we mentioned earlier, this is a prevesical space or Ratzius space where we put or insert our TVT, retropubic needle, because it is safe. There is no blood vessels here, so we can just pass through the needle and comes out here at the abdominal wall incision. And I believe this is my last slide. Here are my references in preparing for the lectures. So all the nice pictures that I get is from these various websites and papers. Yes, that's the end of my lecture. Thank you very much for listening, and I would love to take any questions if there is any, and that's my email address if any of you would like to contact me. Thank you.